update. So this study is a multi-center study to assess the safety and efficacy of RenalGuard therapy in the prevention of cardiac surgery associated AKI. So you all know that, and we already talked about this, that AKI is a common complication after cardiac surgery, especially in patients with certain susceptibilities, for example, chronic kidney disease, diabetes, and chronic diseases. Patients who undergo complex surgery have a higher AKI rate, for example, a combined procedure, CABG, as well as valve replacement. And the AKI rate is, of course, influenced by the definition we use. But nowadays we use the KDIGO definition, and it is important whether we only look for the serum creatinine or whether we also include the urine output. And as we already heard, the AKI rate in an unselected patient population is approximately 35%. It has been shown in several studies that AKI influences short-term as well as long-term outcome. Patients who develop an AKI after cardiac surgery have an increased mortality depending on the severity of AKI that they develop. They stay longer in the ICU and in the hospital. That's the reason why the utilization of the health care cost increases. Patients who develop an AKI, they have an increased risk to receive renal replacement therapy, and this all influences the long-term outcome of these patients, because patients who develop an AKI, a certain percentage also develop chronic kidney disease. Hyman already talked about his single-center study and demonstrated that the device significantly reduced the rate of cardiac surgery-associated AKI. And now we are performing a post-marketing study. It's a multi-center trial with an adaptive study design. 15 to 20 centers in Europe are expected to participate. And it's, of course, a randomized, non-blinded study, because the control group will not receive the device. The device will only be applied in the intervention group. The primary endpoint is cardiac surgery-associated AKI within 72 hours after surgery, and we focus here on the serum creatinine, so we ignore the urine output criterion. And we slightly modified the KDIGO criteria, because normally an increase of the serum creatinine by more than 0.3 milligram per deciliter means that it is an AKI within 48 hours, but our time frame is 72 hours, and that's the reason why we changed this to an increase in serum creatinine by more than 0.3 milligram per deciliter within 72 hours. And of course, the other criterion, an increase by more than 0.5 of the baseline serum creatinine. And we used as an AKI criterion the use of renal replacement therapy within 7 days. And we also look for a safety endpoint. It's a composite endpoint. Here we look for electrolyte imbalance. We look for hypo and hyperkalemia, hypomagnesemia, and hypo and hypernatremia, and the onset of new atrial fibrillation and the development of pulmonary edema. Here you see the main inclusion criteria. All patients who undergo cardiac surgery with the use of a cardiopulmonary bypass can be included, but we of course also perform an enrichment strategy to increase the event rate. So we focus on comorbidities that influence directly the occurrence of AKI after cardiac surgery. So you have to have at least one risk factor for cardiac surgery-associated AKI. You get a risk, for example, patient with a GFR between 20 and 60 milliliter per minute, an increased age above 75 years, And here you can also see that we use the SDS score and or the Euro score, because at the end of the study, and once the FDA study is finished, we want to combine both data sets so that we increase the power, but you also get or you also have an increased risk if your ejection fraction is reduced or you have an insulin dependent diabetes. And here you see the main exclusion criteria. I didn't list all the criteria, but we cannot include patients who undergo emergency surgery because you cannot get the consent from these patients. The patients, the cardiopulmonary bypass has to be used. Patients who are on a higher dose of diuretics, they cannot be included. Patient with a very low GFR, below 20 mL per minute. The reason for this is because here the GFR is so low that it is possible that we cannot modify the trajectory of the disease by this approach, by this device. And patients in cardiogenic shock, which are hemodynamic instability, we don't want to include these patients because here the reason for the AKI is probably different, and that's the reason why we don't want to include them. It's a one-to-one randomization, and the RenalGuard, as I said before, runs only in the intervention group, not in the standard group. The device is initiated once the patient is in anesthesia and the Foley is placed. The device is then connected to the Foley and the therapy starts. We want to recruit 300 patients. It's an adaptive study design, so an interim analysis will be performed after we have recruited 60% of the patients, and then we can increase the number of patients up to 572 patients. And randomization will be stratified by site, baseline eGFR, and the type of surgery. Here you see the algorithm that we want to use in the intervention group. I don't go into detail. It's quite complicated and you probably cannot read it from the back. So, but Hyman already said this, so we want to optimize, hemodynamically optimize the patient. And if the urine rate is below 200, then the patient gets furosemide. So we want to keep the urine rate above 200 after optimizing the hemodynamic situation. So what is the current state of the study? So the trial was registered. 12 centers already agreed to participate. 2 centers were already initiated, and we already have recruited 2 patients so far. And we want to publish the methodology we use, and also we want to publish the main manuscript, the main results. But of course there are also open questions because there might be a change in practice. There are some, or there are at least 2 positive trials in this area. The protection trial, where they demonstrated that the application of amino acid in the perioperative period can reduce the rate of AKI. This might change the practice. And then there is an other trial, another multi-center trial, where they demonstrated that hemoabsorption during the cardiopulmonary bypass can also reduce the AKI rate. And the next question is which co-enrollment is allowed, and this is currently under discussion. So whether we only allow that observational trials can be co-enrolled or also other interventional trials. And with this, I'm at the end. Thank you very much, and I'm happy to take your questions.